بشكر الاول الدكتور شادي على دعوتي للمؤتمر وبتمنى له دايما التوفيق ويوصل اللي هو عايزه اكتر كمان ان شاء الله. And now I have the honor to introduce my colleague, Dr. Mohamed El-Sawy, Assistant Professor of Clinical Pathology in Alexandria University Faculty of Medicine. And the title of the lecture will be Childhood MDS and Looking at the Old Master.
I thank the committee for inviting me for this lecture, and I know I'm a headache guy. I talk a lot, but I like to present very difficult subjects I've been exposed to, and that need more and more attention. And my title is about MDS in pediatric age group, which is considered as a nightmare. And also, I'm very honored to head labs in the Children's Cancer Hospital. I'm seeing a very good promise regarding this hospital and the services given in this hospital. So, what's MDS? It's a group of malignant hematopoietic neoplasms that result in cytopenia and its related complications. There is evidence of clonality, and as the name says, that there is dysplasia in the cells. The rate or the incidence of myelodysplasia is not that high, according to all reports. So in adults in the US, the estimate is around 3.7 to 4.8 per 100,000 population, and usually we see it in very old age. The beginning was a classification generated by French-American British group. We call it third classification 1982. And MDS was classified into 5 categories according to blast percentages and some other morphological criteria. Then the WHO came in 2001 and redefined the blast threshold for AML, which is the next stage after MDS or dysplastic syndrome, to 20%, and the cytogenetics were incorporated in the classification. So MDS had been classified to different subgroups: refractory cytopenia, dysplasia in one lineage, ring sideroblasts, multiple dysplasia, a lot of subgroups, and the pediatric MDS started to pop up as one provisional entity, which is refractory cytopenia child. Then the WHO reorganized its classification in 2008, adjusting the threshold of loss, and some new entities started to pop up in our classification. One of them is that juvenile myelomonocytic leukemia, which is a form of MDS, stayed the same, and they had the myeloid leukemia associated with Down syndrome popping up. So what's the implication of this 2008 classification on pediatric MDS? First, blast count alone was considered not sufficient to differentiate AML and MDS. The diagnostic criteria were based on comprehensive assessment clinically, the course of the disease, morphology, immunophenotyping, and cytogenetics. And they set up limitations so as not to be mixed with the adult MDS. Okay, and there were some categories that were not accounted 4, like pre-existing constitutional syndromes, bone marrow failure syndromes, and the difference between adult and pediatric regarding fibrosis. So finally, some new classifications came, including the WHO 2016, and MDS, MPN in children were classified into 3 main groups. Childhood and myelodysplastic syndromes, which are subclassified into refractory cytopenia of childhood, refractory anemia with excessive blast, and refractory anemia with excessive blast in transformation. Second one, juvenile myelomonocytic leukemia. Third, myeloid disorders of Down syndrome. The myelodysplastic syndromes in pediatrics may be either de novo or primary, okay, in a previously healthy child, secondary to chemotherapy or radiotherapy, and maybe due to constitutional bone marrow failure disorders. 2014, there was very elegant research that came in Journal of Pediatric Hematology, Oncology, and the title was Pediatric Myelodysplastic Syndromes, They Do Exist. So before this, MDS was not taking a good portion or piece of the cake. After this paper, this group started to ask for new classification of pediatric MDS, and they called for the main groups in Europe and the States to reclassify, okay, because this reclassification will be important for the therapy after that. So the WHO in 2016 reclassified its malignant disorders, okay, and some new entities came, like myeloid neoplasm, germline predisposition, some new molecular changes like the TCM1, JAK2 were incorporated, okay, in their classification. And they were trying to solve the mystery of diagnosing this disorder. So the components of the MDS diagnosis in 2016 include preference counts, which is considered as the sine qua non, okay, or the must, which is the unexplained cytopenia. So first, with the peripheral counts, we have to see a cytopenia. Then we have to see from the name dysplasia and blast cells. The count of blast cells is very important in presence of dysplasia. The third one is the genetic studies in myelodysplastic syndrome, which are present in about 90% of the cases. We as pathologists, okay, we need from clinicians, I'm talking mainly to clinicians, we usually need some information, okay? We ask for medical history, some data, some old investigations if you don't have the EMR of the patient, okay? And we need to have a response. It's very important in our lab workup, okay? We need to do morphology review. We need to be really well trained for MDS diagnosis. So a good morphologist will solve a lot of problems. And we need to have very good karyotyping and molecular labs because we give you information that you will use for your therapy. My lecture is a kind of roller coaster brainstorming one, okay? I've been reading in the subject since around 6 years. Very interested in the subject. I gave this lecture 3 times in the Gulf area, and every time it's changing. But this time for our meeting, the Apoc meeting, I've changed it 5 times in 7 days, okay? So bear with me that the amount of data that we need to discuss in other future meetings. So, cytopenia, when we come to cytopenia, if you see blood report, CBC report, okay, when do you consider cytopenia? Okay, it's according to our guide to you through the reference range, adjusted reference range. So the reference range for cytopenia or neutropenia by WHO and IPSS was 1.8 for absolute neutrophil count. According to MDS consensus by WHO 2007, it was 1.5. Anemia, WHO says anemia below 12 grams in females or 13 grams in males that's this threshold, okay? For the WHO IPSS for MDS 10, okay? Platelets, low platelet thrombocytopenia, also from WHO IPSS is less than 100,000. For the other one, 2007, it's 150,000 per microliter. So it's a dilemma. Some people use this, some people use this. So we have to standardize all of this. Okay, so in 2016, WHO started to standardize the MDS. Okay, so the traditional one, ANC less than 1.8, hemoglobin less than 10, platelets less than 100,000 are defining myelodysplastic syndrome. Or we can go to the WHO recommendations, okay, and change a little bit in the cytopenia threshold. But we have to put in consideration the individual reference ranges for labs and the ethnic ethnicity of the patient, so it's becoming more and more complicated. And also, we have to assess the amount of dysplastic cells. So, a cutoff for 10% dysplasia was put for each lineage in the bone marrow. And we don't have to mix them together. So, erythroid, granulocytic, and the platelet series, okay, megakaryocytic series, we have to count each. Okay, but this is subjective, so we have to depend on the eye of the hematopathologist. So it's individual. I can say this, you can say this. You can be borderline, okay, the numbers are borderline, so it's a big disaster. Okay, and then some people came and said, dysplasia is not specific for MDS, so I can be having any other condition with the patient and there is dysplasia. Don't diagnose MDS with just those dysplastic changes. A third disaster. So, is there MDS or no MDS? That was the question. So, in one of the very nice papers by Della Porta that came 2015, he specified the specificity and sensitivity of dysplastic changes in different lineages, okay? And he set up some recommendations for hematopathologists to define dysplasia. Those are the different forms of dysplasia, okay? So some people came and said, okay, we have the new tools. We have the genetic testing, we have the flow cytometry, and the phenotyping. So they started to do some research and work on cases of diagnosed myelodysplastic syndrome, okay, flow cytometric abnormalities. They found that in MDS, a lot of cases are phenotypically abnormal. So it's not just specific for myelodysplastic syndrome. Karyotyping abnormalities, 50% have abnormal karyotype. Subkaryotypic or molecular have a lot of abnormalities in MDS. Okay, the story is getting more and more complicated now. And this is a pattern of flow cytometry abnormality in MDS examples. Okay, the WHO said, okay, we will not take it into account, but it's a kind of supportive data for myelodysplastic syndrome. The story looks complicated now. Yes, we have a child, we're suspecting myelodysplasia. What we will do? An answer came through a very elegant study in the Journal of Blood, setting up somatic mutations in MDS and redefining a lot of mutations in each stage of myelodysplastic syndrome. It's a paper worth reading, okay, to know which abnormality in which stage. And then from a very elegant group in St. Jude Hospital, 2017, in Nature Communication, came a very nice paper talking about genomic landscape of pediatric myelodysplastic syndrome. And in this paper, they said most of the mutations present in pediatric MDS, and one of them was described, which is the SEMD9, SEMD9L change. And I think we have very eminent people from St. Jude with us, and we can connect with them to know more about this subject. So, after that, okay, we're talking about mutations, flow cytometry, karyotyping. Okay, let's put some protocol that we can use in those cases of pediatric MDS. So, there was the old protocol where we do bone marrow examination, and then boom, we have a lot of money, let's do fish, flow, cyto, do a lot of things. We are rich people, so we do a lot of things. But the true story is not like this. We do bone marrow examination, aspirate and biopsy. We do cytogenetics, and according to morphology, we set up either fish for MDS or flow cytometry. And I think now in Egypt we're entering the era of national insurance, which will limit a lot for us, okay, because we will take money from the government, and as you know, in Europe and US, insurance never pays. I'm talking about pediatric MDS. What's the incidence? Okay, 1.8 per million. Okay, so you'll say this guy is crazy, he's talking about something that you don't see. No, it's 1.8 per million. Okay, but all reports coming, they say we are underestimating this disorder in pediatrics. It has a lot of clinical and laboratory features. Okay. The provisional criteria that came, RCC or refractory cytopenia of childhood, there is anemia, thrombocytopenia, and there is severe neutropenia noted in those cases with dysplastic changes, and that's how it looks under the microscope. Bone marrow examination and biopsy, there is dysplasia in lineages. Okay, it has, when we do cytogenetic studies, okay, majority, they are normal. We can find monosomy 7, which is the most common karyotypic abnormality in those cases. Sometimes we find complex karyotyping, okay? And if we look at morphological changes, okay, between patients having monosomy 7 and normal patients without monosomy 7, there is no difference. Okay? To diagnose it, we have to exclude all those conditions. in the patient, okay, including one of the extremely rare conditions, which is autoimmune lymphoproliferative disorder. In children, we can find refractory anemia, and the refractory anemia with excessive blast and excessive blast transformation, okay, and they are characterized by abnormal karyotype, presence of monosomy 7 in a good percentage of the patients, okay. And here in this paper that came 2019 in Hematopathology journal, they were describing differences at the morphology level, okay, between childhood MDS with multilineage dysplasia and refractory cytopenia without multilineage dysplasia in pediatrics. It's worth reading by hematopathologists. What's the prognosis? The prognosis is not that good for pediatric MDS. They turn into myeloid leukemia very fast. Okay. Something I would like to point out to it, which is the bone marrow failure syndromes. They are conditions causing MDS, and we have a lot of conditions like Fanconi's anemia, dyskeratosis congenita, and some other conditions that we have to really see if the patient diagnosed with MDS have them or not. Okay. So one other entity is the familial MDS. Familial MDS, I was in a workshop in MD Anderson 2013 before leaving Egypt and going to the Gulf area. And they had very nice cases, 2 nice cases, okay, for monosomy 7 and pediatric MDS. And that was the time when they were studying one of the genes that were mutated, which is the GATA2 gene. And GATA2 mutations, they cause spectrum of disease in pediatric age group, including familial MDS, AML syndrome, monomac DCML syndrome, and one of the syndromes which is called Emberger syndrome. Another point in this headache lecture, okay, is to exclude aplastic anemia differentiated from the hypoplastic myelodysplastic syndrome, and there are published criteria for this issue. Okay, last headache in my lecture. There are pre-MDS. So pre-MDS conditions. So MDS is pre-leukemia. So we have other conditions which are before the MDS or pre-MDS. And one of them is called CHIP, or clonal hematopoiesis of indeterminate potential, where we find some problems in hematopoietic stem cells. Nothing is abnormal in morphology, only the somatic type of MDS type mutations. Okay, and they found that they turn into MDS and AML later. Some other conditions, like the CHIP, ICUS, CCUS, are also present. And now we have guidelines and criteria to define those conditions, but we have to know all those informations to educate our library in our head to diagnose those conditions. The risk scoring for MDS, it's the International Prognostic Scoring System, okay, and it has been revised, and that now we have the IPSS-R or revised edition for the MDS scoring system. So MDS have the good, the bad, and the ugly in our risk scoring system. So the very low risk score, okay, is the good. There is one high risk somatic mutation or zero high risk somatic mutations, okay. The bad is the low risk plus one high risk somatic mutations or intermediate risk RPI-PSS. And the bad, of course, the intermediate one with high risk mutations and more than 3 high risk somatic mutations, those harboring P53 mutations. And while scanning the literature, I would like to thank Children Cancer Hospital 357 in Cairo. They published one very nice article. They were led by Dr. Al-Haddad, and they had a series of 50-something patients, okay, and they looked at outcome and factors affecting survival of this childhood MDS syndrome. This was published by Pediatric Hematology Oncology Journal 2019, May 2019. So, something else, one of the groups working on this issue is called European Working Oncology Group on myelodysplastic syndrome, and they have one of the very nice meetings in Athens, Greece, okay, in October.